Bismillahirrahmanirrahim. Quote of the day is give every day the chance to become the most beautiful day of your life. Assalamualaikum everyone. I'm Dr. Shajia Javed, PGR Community Medicine, and I'm going to present the topic of stroke under supervision of Professor Dr. Saira Afzal. Learning objectives. In today's session, we will have a definition of stroke and its type, pathophysiology of ischemic and hemorrhagic stroke, risk factors and epidemiology, clinical manifestation and warning signs of stroke, stroke screening tools and their importance, diagnosis, management, recent advances, and their end there will be MCQs. Learning outcomes. After completing this session, learners will be able to understand and accurately classify stroke, their types and underlying causes, interpret stroke symptoms, and apply the stroke screening tools for the rapid diagnosis in clinical or emergency settings, select appropriate image techniques based upon the stroke presentation, recommend appropriate acute and the long-term management strategies for the patient of strokes, assess stroke risk factors and propose preventive measures, understand the global and national burden of stroke and its impact on the healthcare system. Introduction. Stroke is a major cause of mortality and disability worldwide. In 1970s, the WHO defined stroke as a neurological deficit of cerebrovascular cause that persists beyond 24 hours or is interrupted by the death within 24 hours. A stroke is a rapid loss of the brain function because of the disturbance in the blood supply to the brain. A stroke happens when the blood supply to a part of the brain stops, and sometimes it is also called as a brain attack. This picture shows a blood clot originating from an AFib from the heart traveling through the main bloodstream and clotting an artery in the brain resulting into a stroke. Types of stroke. There are three main kinds of the stroke: ischemic stroke, hemorrhagic stroke, and transient ischemic attacks, also referred as a mini strokes. Ischemic stroke is furtherly consisting of a thrombotic or embolic stroke. In a thrombotic stroke, blood clot thrombus blocks the flow of the blood to the part of the brain and the area becomes deprived of blood. While in the case of embolic stroke, a fatty plaque or a blood clot or embolism breaks away and flows to the brain where it blocks an artery, resulting into the area being deprived of blood. While in the case of the cerebral hemorrhage, there is a break in the blood vessel or aneurysm in the brain, resulting into the bleeding in the brain. Now we will discuss one by one in detail ischemic stroke. Ischemic stroke is the most common form of the stroke, which accounts for around 85% of the cases of the stroke. This type of a stroke is caused by blockage or narrowing of the arteries that provide the blood to the brain, resulting in ischemia, severely reduced blood flow. The blockages are often caused by the blood clots. Clots can be caused by the fatty deposits within the arteries called plaques. Hemorrhagic stroke are caused by the arteries in the brain either leaking the blood or bursting open. The ruptures can be caused by conditions like hypertension, trauma, blood thinning medications, aneurysm, or the weakness in the blood vessels. There's an obstruction in the flow of the blood to the part of the brain, resulting area of the brain being deprived of the blood, while in the case of the hemorrhagic case, there is a weakened vessel wall rupture which result into the bleeding in the brain. Hemorrhagic stroke is furtherly considered two main types: intracerebral hemorrhage and subarachnoid hemorrhage. In the case of intracerebral hemorrhage, the bleeding occurs within the brain tissue because of an arterial rupture. It's caused by hypertension, which is the most common cause, cerebral amyloid angiopathy, trauma, or the anticoagulant used. The subtypes include intraparenchymal hemorrhage, where the bleeding is directly into the brain tissue, and intraventricular hemorrhage, where the bleeding is occurring into the brain's ventricular system. The subarachnoid hemorrhage is the bleeding between the arachnoid mater and the pia mater. The causes include the ruptured aneurysm, most common cause, AV malformations, or the head trauma. Symptoms include a sudden severe thunderclap kind of headache, neck stiffness, nausea, vomiting, and a loss of consciousness in severe cases. This shows the cities of a normal brain, showing the front of the head and the back of the head, while in the case of the ischemic stroke, the ischemic area is being presented as a darker gray area. The ischemic stroke, as discussed, considered about 80% of all the cases of the stroke, while the hemorrhagic stroke, which account about 20% of all the cases of the stroke, the hemorrhage of the bleeding is defined as a bright white area on a CT. Transient ischemic attacks or TIA. TIA is often called as a mini stroke because it can cause stroke-like symptoms without lasting damage. They are different from the aforementioned kinds of a stroke because the flow of the blood to the brain is only briefly interrupted. TIs are also similar to the ischemic stroke in a way that they are often caused by the blood clots or other debris. TIs should be regarded as a medical emergency. It's a temporary blockage of the flow of the blood to the brain in which the system lasts less than 24 hours and usually minutes to hours. It can be considered as a warning sign for the future stroke. About 1 in 3 people who have a TIA will have a stroke. The major causes include atherosclerosis, in which there is a plaque built up in the arteries, embolism, small blood clots traveling towards the brain, arterial fibrillation, in which the irregular heart rhythm causing the clots, carotid artery disease, where the narrowed arteries in the neck. The ABCD2 score of the TIA consider of the risk factors like age, blood pressure, clinical features of the TIA, duration, and the diabetes. Each is given a point, and from these points, a score is estimated consisting of the low risk if the score is from 0 to 3, moderate from the 4 to 5, and the high 6 to 7 with the highest suspicion of a stroke after a TIA. Risk factors for the stroke. There are certain risk factors which are fixed, like age, gender. There is high predisposition in the male race. Asians are prone to stroke, hereditary, previous vascular events like MI, peripheral embolism, or the high fibrinogen. And there are certain modifiable risk factors like high blood pressure, heart disease, AFib, heart failure, endocarditis, diabetes mellitus, hyperlipidemia, smoking, excessive alcohol consumption, oral contraceptives, social deprivation, obesity, and sedentary lifestyles. We have already discussed the pathophysiology of each stroke. We will discuss it again. Ischemic stroke, which accounts for about 80 or more percent of the cases, is caused by the thrombotic or the embolic arterial breakage, leading towards the oxygen deprivation and the neuronal death. While the hemorrhagic stroke, which accounts for about 13% of the cases, are caused by the ruptured blood vessel, leading towards the intracranial bleeding and ultimately increased intracranial pressure. Clinical manifestations. Overview of the stroke symptoms. Premonitory symptoms or the early warning signs include dizziness, speech disorder, dysarthria, exhaustion, weakness, hemiparesis, tingling, burning, or the numbness of the skin or paresthesia. Pathological laughter, CS turning into paralysis, thunderclap headache, and the vomiting. These symptoms may indicate many other illness and they are not always the diagnostic sign of a stroke. Most symptoms of the stroke appear suddenly within seconds to the minute. The symptoms depend upon the specific area of the brain which is being affected. Larger the area of the brain being damaged, the more function are being lost. Associated symptoms of the stroke, hemorrhagic stroke consist of loss of consciousness, headache, vomiting because of increased intracranial pressure, and a subarachnoid hemorrhage of the embolic stroke, the symptoms are maximal at the onset. Symptoms also depend upon the subtypes of the stroke. If the central nervous system pathway like spinothalamic, corticospinal, dorsal column, medial and meniscus pathway are involved, it can lead towards hemiplegia, numbness, reduced sensory sensations, and spasticity. If the brainstem is involved, it can result into the altered smell, taste, hearing, vision, dropping of the eyelids, balance problem, altered breathing, muscle weakness of the face and the tongue. If the cerebral cortex is involved, it can result into the aphasia, dysarthria, apraxia, visual field defects, memory defects, and the confusion, while the cerebellar stroke result into ataxia, altered gait, vertigo, and the disequilibrium. This picture again summarizes the signs and symptoms of the stroke. The CV or the cerebrovascular accident result into the headache, mental changes, aphasia, respiratory problems, a decreased cough or the swallow reflex, agnosia, seizures, headache, vertigo, dysarthria, hemiparesis or the hemiplegia, visual changes, vomiting, hypertension, apraxia, or certain facial neurological problems like paralysis, sensory loss, language disorders, or the reflex changes. Diagnosis. Diagnosis involves both the clinical assessment and imaging techniques. The clinical assessment is done by the neurological examination using the NIH stroke scale and the Glasgow coma scale, along with the assessment of the clinical symptoms like facial dropping, arm weakness, speech difficulty, vision problem, dizziness, or the severe headache. This is a National Institute of the Health Stroke Scale, which consisting of the different factors, and each factor is given a point. From point 0 to point 42, that being the highest. 0 has the least chance of this stroke, while the score from the 21 to 42 is considered as a severe stroke. Similarly, GCS is considered of the three different factors: eye opening, motor responses, and the verbal responses, and they're given a score from 3 to 15. The minimum is 3 and the maximum is 15. Stroke screening tools. FAST. FAST is a mnemonic which consisting of F for the facial drop, A for the arm weakness, S for speech difficulty, and T is the time to call the emergency service. Some people also consider it as B fast. They add balance and eyesight issues for the better early detection of the stroke. Other skills include the LABS, which is the Los Angeles Pre-Hospital Stroke Screen, and CPSS, which is Cincinnati Pre-Hospital Stroke Scale. These are the pre-hospital stroke detection tools. This is to spot the signs of a stroke. We use the B fast, B for balance, E for eyesight, F for face dropping, A for arm and a leg weakness, S for speech, and T is the time to call the emergency service right away. While the lapse is the Los Angeles pre-hospital stroke screen time, which is the last time patient known to be symptom free, and the screening criteria include the age considered of 45 years age, no history of seizure or epilepsy, symptom duration less than 12 hours, no previously bedridden or wheelchair, blood pressure, blood glucose, and examination of the face, grip, and the motor functions. Imaging techniques involve the CTs or non-contrast CT is the most common initial imaging test which is used to rule out the hemorrhagic stroke. CT angiography, which help us visualize the blood vessels and detect us helping the blockages. CT perfusion can identify the areas of the brain with a reduced flow of the blood. MRI, these are the most sensitive tests for detecting the early ischemic stroke and a small infarcts. Diffusion weighted MRI DWI can show the stroke within the minutes of the onset, and MRA, which visualizes the blood vessels abnormalities. Doppler ultrasound or the carotid Doppler assesses the carotid artery stenosis, which is the narrowing of these arteries which are supplying the brain. It is useful in identifying the atherosclerotic plaques. Cerebral angiography or arteriography is the gold standard for identifying the vascular abnormalities, aneurysm, or the arteriovenous malformation. It is often used when mechanical thrombectomy is considered. Laboratory tests and the biomarkers, although they have no direct blood tests diagnose a stroke, several blood tests will help us identify the contributing factors. For example, the blood sugar levels to rule out the hypoglycemia, which can mimic stroke. Coagulation tests like PT, INR, and APPT, APTT, they're important in the patient of the stroke who are on anticoagulants. Lipid profile to check for the high cholesterol or stroke risk factors. Inflammatory markers like CRP or ESR, which may indicate underlying condition which are contributing towards stroke, and the cardiac biomarkers like troponin or BNP, which are very much important in the patients having associated heart conditions. Management of stroke. Stroke is a medical emergency which requires the immediate attention. Treatment depends upon the type, onset time, and the patient condition. Ischemic stroke treatment, aspirin reduces the risk of the recurrence by 13%. Thrombolysis within the 3 hours increases the chances of the recovery by the 10%. Mechanical thrombectomy, it removes the clot from the large arteries, like in the cases of the MCA client. It is effective up to 24 hours post-stroke in some cases. Blood pressure and the blood sugar management, cerebrolysis is a derived neurotrophic factor which is often used. Thrombolysis for the ischemic stroke. RTP or LT plays within 3 to 4.5 hours. It improves the functional recovery but doesn't reduce the mortality. 6.4% risk of brain hemorrhage by using RTPA. Intra-arterial thrombolysis, it delivers the medication directly at the site of the clot. It's beneficial in some selected patients. Mechanical thrombectomy, it physically removes a clot from the major arteries. It is effective within 6 to 12 hours, some cases in up to 24 hours. It reduces the disability but doesn't lower the mortality. It is used in combination with the intravenous thrombolysis. Hemorrhagic stroke treatment, it involves supportive care like blood pressure control, monitoring oxygen levels and the blood sugar, stopping anticoagulants, and reversal of the blood thinners if possible. The surgical interventions include the craniotomy or the minimally invasive surgery to remove the bleeding, aneurysm clipping or coiling for the subarachnoid hemorrhage, craniectomy for the severe strokes. It is used in the massive cases of the ischemic stroke with the brain swelling. It reduces the mortality but may result in the severe disability. Hemicraniectomy is a removal of the skull sections to relieve the pressure. Stroke units are the specialized hospital units with the improved survival rates. They use a multidisciplinary approach which monitors the vital signs, BP, temperature, hydration, early mobilization and therapy, and preventing the complications like infections and the bed sores. Stroke rehabilitation. The goal is to help the patient regain their lost skills and improve the quality of their life. We use a multidisciplinary team involving neurologists, nurses, physiotherapists, speech therapists, occupational therapists, psychologists, social workers, and it should begin immediately after a stroke for the best results. Rehabilitation approaches involve the physical therapy, which improves the strength, balance, and the coordination. The occupational therapy, which helps in regaining the daily activities like resting and cooking. Speech therapy assists in regaining the language and the swallowing skills. Cognitive therapy, which aids in memory, problem solving, and attention recovery. Or psychological support, like addressing the post stroke depression and anxiety. Stroke recovery timeline: within the first 3 to 6 months, major recovery occur. Beyond 6 months, there is slower improvement, but the progress continues. Daily therapy and exercise are very crucial for the long term gains. Long term recovery involves continuous rehabilitation for months or even years, home based exercises and the lifestyle modification, support from the caregivers, and the stroke recovery groups. The prevention strategy for stroke involve the primary prevention, which involve maintaining the blood pressure and the cholesterol level, smoking cessation and a healthy diet, and a regular physical activity. The secondary prevention include the antiplatelet therapy like aspirin or the clopidogrel, anticoagulation in the cases of the AFib, and carotid endarterectomy in the cases of the severe stenosis. American Stroke Association talk about the lifestyle changes to prevent the stroke. The steps taken are the do not smoke or vape or avoid the secondhand smoking, eat a healthy food which is low in saturated fat, trans fat, reduce the sugary drinks, do regular physical activity, keep a healthy weight, limit alcohol, take your medication as per direction, maintain your blood pressure. Optimal blood pressure is less than 120 by 80. High blood pressure is the leading cause of the stroke. Reduce the stress, have a regular medical checkups, and get adequate sleeps. This again showed the ways to prevent stroke by maintaining a healthy weight, exercising regularly for 30 minutes, avoiding tobacco, alcohol, eating more fruits and vegetables, knowing your risk and taking the action for them, going for regular checkups, and taking the medicine which are prescribed. Global burden of stroke. According to WHO, annually 15 million people worldwide suffer a stroke. Of these, 5 million die and another 5 million are left permanently disabled, placing a burden on family and the community. Stroke is uncommon in the people under 40 years. When it does occur, the main cause is always a high blood pressure. For every 10 people who die of stroke, 4 could have been saved if their blood pressure had been regulated. Among those who are aged under 65, two-fifths of the deaths from stroke are linked to smoking. Strokes also occur in children, in about 8% of the children with sickle cell disease. Stroke is the leading cause of disability worldwide and the second leading cause of the deaths, responsible for approximately 10% of the total deaths. The Global Stroke Fact Sheet released in 2020 reveals that the lifetime risk of developing a stroke has increased by 50% over the last 17 years, and now 1 in 4 people is estimated to have a stroke in their lifetime. Between 1990 and 2010, the annual incidence of stroke decreased by approximately 10% in developed world, but increased by 10% in the developing world. From 1990 to 2019, there has been a 70% increase in the stroke incidence, 43% increase in the deaths due to stroke, 102% increase in the stroke prevalence, and 143 increase in the disability adjusted life years. The most striking feature is the bulk of the global stroke burden. 86% of the deaths occur due to stroke, and 89% of the deaths occur in the low and the low middle income countries. This proportionate burden experienced by the low and the low middle income countries has been passed as an unprecedented problem due to the families who have with the less resources. World Stroke Organization shows that about 12 million cases of stroke occur each year. 6.6 million will die per year because of the stroke, and 1 in 4 over the age of 25 will experience stroke once in their lifetime. 90% of the cases of the stroke occur because of the 10 modifiable risk factors, and 101 million people are living with the stroke aftermath. This article published addressed the disparities in the global epidemiology of the stroke. It states that stroke is the leading cause of the death and the third leading cause of the disability worldwide. The burden of stroke worldwide seemed to be declined by the past 3 decades, and this reflects mostly in the high income countries. By contrast, the burden of stroke has grown rapidly in the low and the middle income countries, where epidemiological, socioeconomic, and the demographic shift have increased the incidence of stroke and the other non communicable disease. Furthermore, even in the high income countries, disparities in the stroke epidemiology exist, along with the racial, ethnic, socioeconomic, and geographical lines. The key point is stroke is the leading cause of the death and disability. The incidence is rising rapidly in the low and the middle income countries where the health systems cannot cope up with the growing burden. Exposure to the risk factor of the stroke has increased substantially in all the low middle income countries as the global population has aged, living standards have increased, childhood and infectious disease mortality has fallen. Critical resource gaps exist along all the phases of the stroke care delivery, including the pre-hospital, inpatient, and rehabilitation service, especially in the low middle income countries. In high income countries, stark disparities remain in epidemiology along with racial, ethnic, or geographical lines. Curbing the disparities burden of the stroke in low middle income countries and high income countries will require the organized commitment to strengthen the system from the stakeholders at all the level of the local, national, and the global levels. The national burden of the stroke, the WHO estimates that the stroke is responsible for about 9.7% of all deaths in Pakistan. This translates to roughly 141,432 deaths per year. The incidence of stroke is estimated to be around 250 per 100,000 per year. The published stroke prevalence study from Pakistan, conducted on adult Pashtun community which are residing in Karachi, reports about 4.8% prevalence of the stroke in a community with a similar ratio in the men and the women. And 30% of all the stroke cases were reported to have occurred at the age of the 45 or less, suggesting a high burden of the young strokes in Pakistan. According to the WHO latest published data in 2020, stroke deaths in Pakistan reached 141,432 or 9.69% of total death. The age-adjusted death rate is 116.52 per 100,000 of the population, and Pakistan ranks at number 51 position in the world in the number of the death by the stroke. The stroke in Pakistan, the high prevalence of the risk factors. Pakistan faces a high prevalence of the established stroke risk factors, including hypertension, diabetes, or smoking. Younger age of the onset, studies indicated that stroke in Pakistan often occur at a younger age compared to the Western countries. Limited acute care, the availability of the specialized stroke units and access to the treatment like intravenous thrombolysis are limited primarily due to the financial constraint and the shortage of the trained healthcare professionals. Need of the public awareness. There is a critical need to enhance the public awareness about the symptoms of the stroke and the importance of the timely medical intervention to improve the outcomes. The article recently published addresses the deficiency in stroke care in Pakistan. It states that the current healthcare infrastructure is not equipped to handle the need of the patient with the stroke. There is scarcity of the imaging available. Like there are only 80 CT scans available and 19 MRI machines, and they are mostly concentrated in the major cities. Additionally, there is an absence of a national registry for the stroke patient, which hampers the collection of the data accurately. Pakistan also needs more neurologists and healthcare workers. The country has fewer than 200 neurologists. There's also a shortage of the allied healthcare professionals, including physiotherapists and the speech therapists, who are very much essential for the rehabilitation of the stroke survivor. Investing in a more stroke unit, especially in the rural and undeserved areas, is very essential. There is a need to ensure that all the major hospitals have the necessary diagnostic equipment, including CTs and MRI. There should be a quick triage and the treatment protocol to improve the outcome of the patient. There's a need to increase the number of the trained neurologists and the healthcare provider. There's a need to do the collaboration with the international institution for the training and certification program. Improving the stroke care in Pakistan requires a joint effort from the government, healthcare providers, and the community. Machine learning application in stroke medicine, advancement, challenges, and the future perspective. Stroke is the leading cause of the death and disability worldwide, necessitating the development of the advanced technology. Machine learning techniques have emerged as a promising tool in the stroke medicine, enhancing the efficient analysis of the large-scale dataset and facilitating the personalized and the precision decision making. Recently introduced machine learning algorithms have been extensively employed in all the fields of the stroke medicine. Machine learning models have demonstrated remarkable accuracy in learning analysis, diagnosing subtypes, risk stratification, guiding medical patient prognosis. The machine learning data processing is involved for the purpose of the data collection. For demographic data, medical history, lifestyle factor, biological and physiological data, laboratory results, neuroimaging, genomic, or the clinical presentation. It is also used for the post-stroke rehabilitation data, follow-up data, medication use data from where the variable devices, socioeconomic environment, or the dietary data. For the diagnosis optimization, machine learning has been employed to use the medical image recognition, EEG signal analysis, early detection, stroke prediction from the electronic health data, prognosis optimization, predicting the recovery outcomes, anticipating the complication, improving the follow-up care, or predicting the long-term outcomes. And the treatment optimization has also been enhanced by the machine learning data processing. It helps in guiding the rehabilitation plan, evaluating the treatment effectiveness, personalized treatment planning, and drug discovery and development. In conclusion, machine learning has the potential to significantly improve the diagnosis, care, and the outcome of the stroke patients. WHO also understands the morbidity and mortality caused by stroke. Strategic action to reduce the stroke mortality, according to WHO, is preventing stroke and minimizing the recurrence is one way to make significant stride towards achieving the Sustainable Developmental Goal number 3, which aims to reduce the premature mortality from the major non-communicable diseases by a third by 2030. Central to the concerned efforts is addressing one of the primary risk factors for the stroke, which is hypertension. Hypertension is diagnosed and managed through the standard treatment protocol and team-based care in the primary care setting. Additionally, improving access to the essential medicine and medical devices for the individual who are diagnosed with hypertension is also critical in an effort to prevent stroke. Other modifiable risk factors include the tobacco use, use of the healthy diet, physical inactivity, diabetes, alcohol consumption, and socioeconomic deprivation. Strokes are often sudden and life-threatening events, and they can be prevented and treated. For this purpose, a World Stroke Day is celebrated every year on October 29th. Now, MCQs. The question number one is: a 65-year-old man suddenly develops slurred speech, facial dropping, and weakness at his right arm. His symptoms resolve within 20 minutes. What is the most likely diagnosis? A. Ischemic stroke, B. Hemorrhagic, C. Transient ischemic attack, D. Brain tumor, and E. Migraine. C. Transient ischemic attack is the right answer. Um, Question number two: a 70-year-old patient with a history of stroke is being evaluated for the secondary prevention. What is the most effective measure? A. Vitamin supplementation. B. Long term bed rest. C. Antiplatelet therapy. D. Daily glucose monitoring. Or E. Herbal medicine. C. Antiplatelet therapy is the correct option. Number three: a 45-year-old hypertensive patient is diagnosed with an ischemic stroke because of a large arterial clearance. But the best immediate treatment? A. Aspirin alone. B. IV thrombolysis with RTPA. C. Anticoagulation with heparin. D. Statin therapy. And E. Carotid endarterectomy. B. IV thrombolysis with RTPA. Number four: a stroke patient is found to have high cholesterol. What class of the medication should be prescribed for the stroke prevention? A. Beta blockers. B. Calcium channel blockers. C. Statins. D. Antipsychotics. And E. Proton pump inhibitors.
C.
Yes, C is the right option. Number five: which of the following is an important feature of a TIA? A. It causes permanent brain damage. B. It lasts more than 24 hours. C. It can be ignored since symptoms resolve on their own. D. It is a warning sign for the future stroke. And E. It is usually caused by hemorrhage.
D.
No, C. D is the warning sign is the right option. Six MCQs. Which preventive strategy is most effective for reducing the stroke risk? A. Blood pressure control. B. Herbal supplementation. C. Sedentary lifestyle. D. Eating a sugar diet. And E. Avoiding water intake. Six. A. Blood pressure control is the most important preventive strategy. Number seven: a patient has symptoms of stroke which affect the cerebellum. Which of the most important symptoms is likely to occur? A. Hemiplegia. B. Aphasia. C. Ataxia. D. Visual field defect. And E. Pathological laughter. C. Ataxia is the right option. 8. Which of the following imaging modality is the most sensitive for detecting an early ischemic stroke? A. Non-contrast CT. B. MRI with a diffusion weighted imaging. C. Carotid Doppler. D. PET scan. And E. X-ray. B. MRI with a diffusion weighted imaging is the correct option for this MCQs. Number 9. A 62-year-old patient presents with a sudden left-sided weakness and difficulty in speaking. A non-contrast CT showed no hemorrhage. What is the next big step in the management? A. Start aspirin and monitor. B. Administer IV thrombolysis with RTPA within 4.5 hours. C. Perform an immediate carotid endarterectomy. D. Prescribe warfarin for the anticoagulation. E. Order a lumbar puncture. B. Administer IV thrombolysis with RTPA within 4.5 hours is a correct management plan for this stroke. Number 10. A 55-year-old hypertensive patient has a hemorrhagic stroke. What is the initial management priority? A. Rapid blood pressure control. B. Immediate thrombolysis. C. Start anticoagulation therapy. D. Perform carotid endarterectomy. Or E. Administer aspirin immediately. A. Rapid blood pressure control is the correct option. This is the key to the MCQs. the link to our YouTube channel where the presentations will be uploaded. Thank you.